Good morning, everyone. Welcome to one of the most awaited sessions in the meeting. We will address a confluence of two critical medical challenges, the global obesity epidemics and the widespread occurrence of hernia surgery. So having the two problems in a patient put surgical challenges and magnify surgical challenges. So this session objective is to provide clarity on the preoperative management, prioritization, timing, surgical techniques, and how recent technological advancement like robotic can change traditional practices. So we are privileged to have an esteemed panel of experts to guide us through these intricacies. And I'm also honored to introduce my co-chair, Madam President of the American Society for Metabolic and Bariatric Surgeons, the only and great Marina Curian. Thank you.
Thanks so much. You know, I was excited to come and do this session mainly because when I keep doing my research, I keep getting all the bariatric hernia questions wrong. So I look forward to all the discussion, and there are some housekeeping announcements. So this is the final day, as you all know, and AHS wants to thank industry partners for all their support of the meeting. And today's highlights, including the final round of the Hernia Olympics and the closing awards ceremony, where the winners of the research grant, the Hernia Olympics, and other meeting awards will be announced. And you guys can get CME and self-assessment credit. The deadline to claim is October 23rd, and you can get it online or through the meeting app. And if you're staying in Austin, join AHS for a kayak tour at 4 p.m. You can stop by registration for details. And then the message is thank you for joining us this year. Mark your calendars for 2024, September 12th to the 14th at the Swiss Hotel in Chicago. So to start the session, I'd like to invite Bonnie Lee up. She's assistant professor at the University of Southern Alabama, and the topic is the basics of the problem. Does robotics make it better?
That's on. Thanks so much for having me. I have no disclosures. So we know that in the United States, obesity is an epidemic. For the CDC reports, 42% of US adults and 20% of children are affected. And this accounts for approximately $147 billion in annual healthcare costs. Similarly, a staggering 39% of the global population is also obese. My practice is in Southern Alabama, so I routinely see patients with BMI 40s and sometimes in the 60s. This is a patient with BMI 62. And as you can see, her hernia actually goes outside the view of the CT scan. But on the bright side, Alabama, we are only the third most obese state in the nation because West Virginia and Kentucky have us beat. We already know that obesity leads to hernias. And we also know that obesity leads to hernia recurrence. This was a paper that looked at 5,200 patients who underwent a laparoscopic IPUM repair. And it showed that in patients with BMI greater than 30, there was a significantly increased risk of recurrence. So what about obesity and infection? Significant predictors of postoperative surgical site infection include BMI greater than 30, smoking, ASA class 3, an open surgical approach, prolonged operative time, and also if there's an inpatient admission following the incisional hernia repair. In a retrospective review of the NISCLIP database, they looked at 102,000 patients, and they stratified all of these patients who underwent open ventral hernia repair according to their BMI class. So as you expect, there's a steady increase in complication rates as your BMI class is higher. So in that case, what do we do with these? The obvious answer is to optimize, counseling the patient on losing weight, stopping smoking, improving their A1C if they have diabetes. But the problem is that most of the patients I see with large hernias are low income. And as someone who subsisted off ramen and Hello Panda cookies all through residency, I can tell you firsthand that junk food is cheap and healthy food is expensive. Another surprising issue that I've run into is getting patients into the bariatric clinic because a surprising number have not been able to have their insurance cover it. So that's definitely been a problem that I'm not really sure how to circumvent. Not a very few of the patients that I see will actually get optimized, get their goal optimization criteria. So even so, it's really hard to turn down a patient when they're telling you that they are not allowed to go to work because Walmart thinks that their hernia is a liability. So I do end up doing a lot of hernia repairs on patients who have a BMI greater than the recommended 35. So in this situation, what should be your surgical approach? We know that obese patients do better with a laparoscopic repair as opposed to an open, just due to the decreased risk of wound infections and complications. This paper showed that with a laparoscopic approach, the infection risk is 5 times lower compared to open. And the laparoscopic approach affords fewer complications, shorter hospital stay, lower incidence of reoperation, and lower rate of wound issues. So that's all these factors make the laparoscopic approach more cost-effective than open. In terms of mesh infection, there's a really low rate of mesh infection after a laparoscopic ventral hernia repair, 1 to 2%. And in terms of hernia recurrence, they found no significant difference between the laparoscopic and open approaches in terms of hernia recurrence, and their follow-up was up to 35 months. This has been validated by several studies, but the issues with these studies is that they're using different meshes, they have different hernia sizes and locations, they have variable surgical risks, and there's a lot of variability in the operative technique being used in these analyses. So we know that the laparoscopic approach, when feasible, is superior to the open approach. So where does robotics fit into this? I think that all the advantage of the laparoscopic approach do translate to the robotic platform, just because robotic really is a laparoscopic surgery with the addition of more expensive gadgets. So in terms of robotic versus open repairs, this paper looked at 3 randomized controlled trials and 22 observational studies. And it showed that with the robotic approach, there was a longer duration of operation, but there was also fewer transfusions, shorter hospital stay, and lower complication rates, although they didn't actually specify what complications they were looking at in the paper. There was no significant difference in cost between the robotic and open approach. And the most common repair that they were looking at in this comparison of robotic and open was a retrorectus repair plus or minus a TAR. In terms of the robotic versus straight stick, this paper showed that robotic also has longer OR duration, and it was more expensive than the laparoscopic approach, but no different, but it was more expensive than laparoscopic, but again, they stated that robotic had the same cost as open. Between robotic and lap, there was no difference in conversion to open, and there was no difference in the length of stay. The most common technique they looked at for this was IPOM. When they compared the 3 approaches of robotic versus open versus lap, they showed no significant difference in the rate of intraoperative complication and the surgical site infections, readmission, mortality, pain and recurrence, which I actually find kind of interesting because there's so many other studies that show that the laparoscopic have decreased risk of surgical site infection and pain. So just with all this information, you have to take it with a grain of salt, because at the end of their study, they basically concluded that aside from the known fact that robotic takes longer, they really had a low level of evidence for all of their other conclusions. So take from that what you will. So then the question becomes, is robotics too costly for us to be utilizing for these repairs? The data is problematic because a majority of studies do not actually define the items included in the cost estimates. And I think that over time, as the robotic approach becomes more common, as surgeons and the OR staff become more efficient at utilizing the robot, that we're probably going to see a cost benefit from the robotic platform just because of the decreased length of stay, even though there is definitely upfront cost associated with robotics. So if laparoscopic is known to be superior to the open, and the robotic is more expensive than the laparoscopic approach, and the robotic and laparoscopic approaches are equivalent, why not just do all of the repairs laparoscopically? Well, I think that definitely for repairs like eye pump, laparoscopic is certainly a reasonable and viable technique. But as for a TAR, I do not have a skill set to do a TAR laparoscopically. So for me, if I'm doing a TAR, it's going to be open or robotic. Additionally, I think that there is a ergonomic advantage to the robot, and the fact that you're able to sit down during the whole case is a game changer and can really increase the longevity of your career. But at the same time, it's still pretty entertaining to watch videos, old videos of your attendings doing this laparoscopically. I'm not sure I would be able to do all of that kind of maneuvering and positioning for the duration of a TAR if I had to do it laparoscopically. In addition, I don't enjoy exercising, so the idea of having to push the laparoscopic trocars against a thick abdominal wall is very unappealing to me, so I'd rather have the robot do the heavy lifting for me. So back to the question, does robotics make it better? I think that in a lot of ways it does. I think the robotic approach affords a lot of the advantages of the laparoscopic approach in terms of decreased length of stay, decreased wound complications, decreased pain, and decreased pulmonary issues. And I also think that the ability to not have to strain your neck and your back and your legs standing all day in a terrible case is a big quality of life issue and can definitely keep surgeons in the game for longer. This was a paper that looked at the outcomes of morbidly obese patients after a robotic ventral hernia repair. And it showed that it was a safe repair with good outcomes and low recurrence rate. This was a study done on 50 patients with BMI greater than 40. And the repairs used were TAP, IPUM, retrorectus, and component separation, all done by a single surgeon. They showed that the hernia recurrence was 2%, so 1 patient out of 50. And there's a breakdown of the surgical site infections, the seromas, and hematomas. And overall, the clavia and dindo class 3 and 4 comprised 6%. Here's a couple of cases that I did on patients with BMI in the greater than 40. This particular patient had a lot of bowel encroaching that hernia, a lot of discomfort. Her BMI was exactly at 40. And she is a couple of months out and doing really well. This is another robo TAR I did, and you can just see that there's just holes everywhere up and down her entire length of her abdomen, but it still came together very nicely. That's her pre and post-op videos. So I think that it is very rewarding to do these repairs in patients. This particular patient was BMI of 41 at the time of surgery, and he's continued to lose weight since I do aggressively counsel patients on the importance of a trend of weight loss in order to preserve their repair and prevent a recurrence. But it's great when you get messages like these, although I did tell him that I cannot fully support him riding a motorcycle since that's how he got his hernias in the first place. That's all I got. Thank you so much.
Thank you very much. The questions are going to be entertained at the end of the session. It's a pleasure for me to ask Eduardo Parra Davila to come to the stage. Eduardo is an expert in bariatric and colorectal and abdominal wall reconstruction, so nobody is more prepared for this topic on optimizing the patient with obesity for ventral hernia repair. Where to start? Where?
Thank you for the chairs. Disclosure, I'm not an expert in bariatric surgery. I want to be an expert in bariatric surgery, that's different. Thank you so much. So I started doing bariatrics a little while ago. So this is a talk on how to optimize this. I got no disclosures related to this topic. So obesity is a risk factor, as we know, for development of hernias and recurrences. We all know that. The question when I started looking for this talk is there consensus for optimization preparatively? You'll be surprised what you find. You find no, maybe, yes. So our literature is kind of confusing. There's some papers that show that maybe no, we shouldn't do it. Like they found, and this you can see the title, where the hernia recurrence, hematoma, surgical site infections are the same as non-preoperative optimization, so they see no difference. There's another paper from the European Hernia Society that says prehabilitation prior to hernia surgery may be widely used, however, the evidence is limited. Is there consensus for yes? There's some papers also saying yes, and should we do it? And these are some papers. This is a recent paper from 2023 where they start comparing if you can control the comorbidities, you will have the same results of the patients without those comorbidities. And I'm not going to go into algorithm because Ian is going to go through that, but this is a simple paper showing that just by smoking, BMIs, physical condition, diabetes, pulmonary, we do this routinely on a daily basis on surgical patients, what we do. This is another paper by Kutsi and by Professor Dietz, saying he categorizes depending on is it emergent, is it semi-elective or elective, and if it's emergent, we know the answer is they go to surgery and then we deal with the problems later. If it's semi-elective, can we do the ventral hernia and then deal with bariatric or weight loss later? Depends on what their symptoms are. And elective procedures concomitant with bariatrics or after the bariatric surgery a year later. This is also an interesting paper going over BMIs of 30 where they categorize favorable versus unfavorable if they're gynecoid or android, and if the width of the defect is greater or less than 8 centimeters, and if the subcutaneous fat is greater than 4 centimeters. And this is the algorithms. You can see it. There's the citation. You can follow it. It's kind of a little bit not as easy as I'm sure Shane is going to show his algorithm. This is another one that is easy to follow. Just look at the column on the left side, things that we always looked, then you optimize them, and then you get the outcomes, and you get the specialist to optimize them. So the question is, where should we start? And the first office visit, that's where we all start. What is the interview, the physical exam, what's the BMI, what type of shape is the patient, obesity, comorbidities, any history of surgery, mesh prior, had infections, had VACs before, we need CT scans, and what will be the approach, MRIs or open. Now that seems to be what we need to have before. And then you have to ask him, are you symptomatic or not? Is this something that has to be done right now or can wait at a later date? And what kind of repair we're going to use? And then you have to talk about patient expectations. This is one paper showing that the body mass over 35 will increase your recurrences post-op. So we shouldn't not only look at the comorbidities after the surgery, we have to look at 1 year down the road what's going to happen with this patient, and recurrences are increased in this kind of patients. Here you have the two shapes. I'm not worried about the patient on the right side of see that, I don't have a point. Well, on the, it says on the gynecoid obesity versus the android. This is a different types of obesity. Not only because you're obese doesn't mean that you can be malnourished. So you also have to test these patients for malnutrition because there's a category that will be malnourished even though they are obese. CT scans is something that we look at. When the previous presenter was showing, one thing is with this subcutaneous tissue and laparoscopy is a problem. I have been instruments trying to do hernias in these kind of patients. Robotics can help. I totally agree. But subcutaneous fat and visceral fat are totally different, as well as, for if the need for component separation, as well as complications post-op. This could be some red flags if you have something that, is greater, if a greater width and the increased subcutaneous tissue. This is a patient of mine that I bent the instruments. I ended up doing it robotically. That's, this is real, and the patients have this kind of, open is a problem. So a lot of the literature shows that open is a problem. Sometimes we do laparoscopic or minimally invasive surgery, and these issues can be forgiven. You can see the pressures inside here. You can see the mesh right there at the edge of the arrow, and this is 15 centimeters of fatty tissue in the subcutaneous, and the patient looks like everything wants to pop outside. These are difficult patients to take care of. So what do we do with these patients? For weight loss, we got medical weight loss and we got surgical weight loss. The medical weight loss, you got decrease the calories, replace the meals with proteins. You also have pharmacotherapy these days. There's a lot of pharmacotherapy these days are being used to try to optimize these patients. And in the surgical arm, you got from the gastric balloon, gastroplasty, sleeve gastrectomy, and gastric bypass. So, and the question is, you should tell the patient, should we do concomitant surgery between morbid obese and ventral hernia? Well, this is some paper showing that if you do that, usually you're going to have higher rates of readmission, intervention, reoperations, including death, and also you will have increased early morbidities in these kind of patients. So this is a patient of mine that morbid obese that I did. He has a gastric balloon for weight loss. For obvious reasons, you see you can feel the balloon in that area. This patient underwent, after about 6 months, underwent surgery, and you can see the result on what this patient is. This is another patient. We did a sleeve gastrectomy. The patient, this is something you have to discuss with patients, what can go wrong afterwards. This patient had an ulceration. You can see there on the bottom with small bowel almost exposed. So I have to take her before I wanted to take her. This patient ended up with an open procedure. This patient was discussed to have a visceral reduction. You can see it there for making space. And then this is the final. So you have to be prepared and set the expectations for these kind of patients. So what do we do with the medical history? We do diabetes, COPD, non-alcoholic liver disease, substance abuse, and frailty. And we know that diabetes is a problem and increase our SSI and impair wound healing. We know the values that we have to be, so definitely this has to be addressed. We also know that 50% of these patients with diabetes will be obese, and they have a 3-fold increased microangiopathy on the large vessels. So they take us to the exploration of what's going on in their cardiovascular conditions. The cardiac events, hypertension is 6 more times in these kind of patients, as well as fibrillation is about 50% more. And the symptoms sometimes that these patients have may not be related to the heart, it may be non-specific on obesity, like dyspnea on exertion, lower extremity edema, etc. But we have to address this, and don't be surprised that sometimes with normal EKGs, your patient has cardiac conditions. Increased pulmonary functions, these patients are known, a lot of them, to have sleep apnea, so they have to be studied for this, as well as we know that once we put inside the contents, the intra-abdominal pressures can increase and can create all kinds of issues post-op, as well as recurrences at the long term. Some papers show that obesity may not be an issue if you do minimally invasive, but if you do open cases and the volume of the hernia on the outside and the inside to 0.56 is what is the most likely the factor that will be having issues in the respiratory part, and that you should be aware with the CAT scan on these patients, regardless of their obesity status. This was a surprising. A lot of these patients then get overseen for non-alcoholic fatty liver disease. 85% of the BMIs over 40 will have this condition. What is scary about this, as you can read down in the bottom, is 22% will develop diabetes mellitus, 22% will have hypertension, and 25% of these will die of coronary artery disease between 5 years of that diagnosis. And this is, you can see that on CAT scans, you can see that in a lot of tests, so don't forget about this. because it's overlooked a lot of times. About tobacco and dependence, this is surprising what we see in the literature. We always been predicting that, we need to stop smoking, you need to do this and that. Well, it looks like the literature can be a little bit misleading, or we were wrong for the last 20 years. So smoking cessation, they said that, yes, it impairs the wound, but they're talking basically about open incisional hernias and also pulmonary complications and open incisional hernias. If they go minimally invasive, it may be that this may not be as much as we thought it was before. This is a patient, another study showing some highlights regarding that if you stick to the program to decrease the smoking cessation, and they separated the patients in 3/3, the patients that adhere more to this have lower ER admissions in the 30 days. So again, you can, I think it's not unreasonable, I'll say it that way, to make them cease smoking. I'll do that on my patients regularly. Then it goes through frailty. Who's frailty? You can see the patient walking to your office when it's exhausted. They can even, catch up their air. And we see a lot of patients with morbid obesity like that. And we also have to consider the psychological frailty as well as the social frailty on these patients that as well is very well overlooked as well. The meds, you can see if you have less than 4, you should be optimized. If you're more than 4, they're considered that you can go. But this was in one paper in Lancet, was considered too subjective. So they wanted to see the Duke's activity status, and you can see it there. And if you divide this by 3.5 and it's above 4, then you're supposed to be okay to go with surgery. So there's different measures that you can do in these patients. But again, if you look at the prehabilitation for physical therapy, they say that there's the evidence surrounding the therapy before this improves in every other specialty, but in our specialty is limited. It's limited the information that we have. On top of it, if you're doing physical therapy, there's a paper suggesting that these patients has a higher conversion to emergency in the prehabilitation status. Now, I lived that myself, and I'm going to show you a case that, I try to optimize, and it actually happens. And it's no significant difference at the end of prehabilitation. So this is, I did this a couple of days ago, showing us, can you optimize physical therapy? And the data is mixed. Some people says yes, some people says no. So if these things happen, you have to be prepared for the worst. I tried to optimize this patient. This patient came with morbid obese, inguinal hernia, came to the ER several times, incarcerated, come off. The pain was getting to him several visits, so we decided to take him. We didn't have any time to optimize the patient. And you got to be prepared for this. Cases are kind of difficult cases. You have to, everything you have learned in back systems, etc., you should be prepared for this. So that patient actually had a good outcome. We sent him afterwards for bariatrics, and then I lost the patient after that. This is a patient he's from Miami and was coming to us. I'm about 60 miles. And I was telling him, hey, we're gonna lose some weight, and you may have some issues when I reduce all this. He was actually very compliant, started losing weight, going physical therapy. 3 o'clock in the morning, he comes incarcerated. So I went robotically, tried to do it, couldn't reduce it. I did a counter incision, and then I finished the case robotically. So these are hybrids. The message here is you should have every momentary you can have to help these patients because they're in need of every technique that we have. So to finish, and my summary is in some cases it may be necessary to postpone the hernia surgery until the obese patient has lost some weight. And I agree with this. I think, the comorbidities, the patient is in better shape, even though the literature can be misleading. Patients above 40, definitely, I think they have to be optimized. And overall, it's your decision to see which patient and when to do these patients, and do the best you can and account the individual patient's medical history and risk factors. Thank you very much.
Todd Hennefert's going to talk on mathematics, charm, and the reluctant patient, best strategies to get patient buy-in.
Fantastic. If we can get the slides, please. Thank you very much for the American Hernia Society for this privilege of the podium. At those slides. You're ridiculous, dude. That was just amazing. These are my disclosures. I will say that the most important disclosure on there is, to me, is the charity that we started last year that to benefit prostate cancer. If you go to the website, we actually have an auction up now to support that. My other disclosure is, like, I'm a hardworking surgeon. You know, the people who actually do the work are the young people that we train. Anything that comes out of this that's worth a damn is because of them. It's I don't do any research. I just kind of like stand in the background and let all these young people make me look smart. The first time I ever gave a lecture about comorbidities and preoperative assessment of patients was about 12 years ago. And this was in Europe, and essentially when I talked about stopping smoking and obesity and diabetes, I was almost heckled out of the room. And then now, the crazy thing is that we're still talking about it. And I just want to be clear. Like, there was a conversation earlier this week about smoking versus not smoking, and is it okay? It's not okay. If you think your outcomes are going to be the same, they're not going to be the same. Every point of BMI that we decrease, we improve our outcomes. We decrease pressure in the abdomen, decrease our recurrence rate, decrease wound complications. Diabetes in 2013, diabetes was the #1 reason for wound complications, which then led to recurrences in our practice. So if you want to be a good surgeon, you need to be a good doctor, or call yourself a technician. You know, if you want to be special, you want to be a specialist, do something special. Or just call yourself a technician and be average. I mean, I don't even know why we're still having these debates, honestly. There's a lot of things you think about when you go in and talk to patients, absolutely. And so 4 years ago, one of our fellows asked me to write down what I think about what I consider when I'm going to talk to patients. And I wrote this down in one go, and he made a slide out of it. But absolutely, there's no question, all of that leads to these outcomes. For us every day to be able to do this and do it regularly with good outcomes. But, you know, taking a patient and changing their lives like this, it's not just what we do in the OR. What it is, it's all of it. And if you miss pieces of the puzzle, you miss pieces that develop good outcomes, then you put them in a randomizer and expect those outcomes. No question, we've all seen surgeons who are really technically good, and they have great outcomes, or they have better outcomes than the average surgeon. But as Clifford Albert said, and he was a surgeon who was president of the British Medical Association 100 years ago, he said, what we have to do, indeed, the technical considerations of surgery are super important, but what we have to do is now apply science. And we know in hernia repair, the application of science, and we've talked about it this week, is not very good, but it's the best data that we have. And I will tell you, it is like, this is a time scale. You can see that the blue here is like the amount of time that I used to spend when I was just a hernia surgeon. But now the time that I spend preoperatively is much longer than it was. But what I'm doing postoperatively is I get that time back. But if you don't do this, and you only do that, you may be much better technically than I am, but you'll never be a better surgeon than me, and absolutely not a better doctor. And so when we see patients, you know, one of the considerations that, you know, I think about in patients, that big, broad thing I showed with all these things that I think about in patients, absolutely. But I spend so much more time now with patients preoperatively, and I sit down at eye level with them, and I talk to them about, you know, one, their symptoms. I'm a quality of life doctor for most of these people. I'm not saving lives. I'm improving their quality of life. But one thing I don't compromise on is this prehabilitation. And I set preoperative hard nose. And I'm not their mother, and I'm not their minister, and I'm not going to browbeat them. I'm their surgeon, and I'm their cheerleader. But I set hard nose. This is absolute no. And in like the consideration, like, Todd, how do you get people to lose weight? And we actually are pretty successful with this. I will tell you, there's a lot of bias in our data. And the bias in our data comes because most of the patients that we see have multiple hernia failures. So when they walk in our office, they're like, you're my last chance to get this done. But one thing is also true is I use that time Like, I spend my time talking to them. I actually draw on the, we have whiteboards in every in every exam room. And I spend my time up front setting, like, this is what a hernia is, this is what we plan to do, this is where I would choose to put the mesh. And I go through that with them. And we develop a partnership. And I do talk to them about the consideration of like complications. And there's no question, if you look at body mass index and wound complications, even a small change for every point of BMI, that we decrease the chance of complications by about 6%. And so people say, well, what about, do you have a break point of body mass index of 40? I don't. You know why? Because 39 is better than 40. 38 is better than 39. If you come in and you have a body mass index of 32 and I'm going to operate on you, I say, hey, can you lose 10 pounds before we operate on you? I'm going to squeeze my margins as much as possible. And I tell the patients this. I said, the reason I want to do this is I'm not trying to torture you. What I want is the best possible outcomes for you. And so my consultations with patients now are much longer than they used to be. I get that back at the end. And I like, will patients go to see another physician? They may very well. But one thing is certainly going to happen is if I operate on them when they're highly comorbid, it's going to catch up with me. I do talk about a ketogenic diet, and we can talk about that later if you want. I mean, genetically, how a ketogenic diet, we were hunter-gatherers for 75,000 years, and how if you have sugar in your diet, you hold on to your fat. We're like bears. Bears have a high sugar diet, they put on loads of fat, and they burn their fat in the wintertime. We just don't have winter in the United States anymore. 78% of what's in the grocery store has added sugar in it. You know why? Because it tastes good. So I talked to them about a ketogenic diet, and then Ed went through this very well. But we first start, I'll back up for a second. Like, this is Celia Yuzo's work. One of the things that we found is if you will actually spend time with the patients and talk to them, they respond to that. One of the things that Sully did is he actually did a walking. He actually took patients for a walk, measured their 6-minute walking speed, how far they could walk in 6 minutes. But he took them for a walk. Spending that time with them, what happened? 100% of the patients complied with this. On average, they lost 15 pounds, and they increased how far they could walk by over 900 feet prior to surgery. It's that time spent with them, the investment, and I totally believe in it. What do we do in patients who don't lose weight, or the patients that we send home to lose weight? I used to just watch them. Call me when you've lost weight. What we do now is every week on Monday and Wednesday afternoon, we have a call list. My nurse practitioner or I, or the fellow, start calling patients. How are you doing? What's your weight doing? How can we help you? First step, lose weight on your own, ketogenic diet. Second step, dietitian. Third step is pharmacotherapy, or seeing a bariatrician, or bariatric surgery. We have a stepwise progression with these folks. But you can see all these phone calls with patients. We now chase them because we don't want to lose these patients, but also, two, we know what's best for them and for us. Now, why would you do it? This is data from plastic surgery demonstrating increasing body mass index and wound-related complication recurrences and also reoperation. This is our data. We now can track our patients and weight loss in our patients and what this equals. So if body mass index reduction, for every point of body mass index reduction, we actually save about $3,000 in charges in patients because of complications associated with body mass index. How about small hernias? Well, just a patient just has an umbilical hernia or an epigastric hernia. And this is data from Denmark. And if you look at this down here, I'm sorry, I apologize, it's so small. What this is, BMI greater than 40, you have a 6-fold increased chance of readmission to the hospital because of complications associated with an umbilical hernia or an epigastric hernia. How about bigger hernias? And so this is, we talked about small hernias. We divided bigger hernias, defect less than 200 square centimeters, greater than 200 square centimeters. And this is statistically significant. So for smaller defects in our hands, BMI is important. But for larger defects, if you're going to call yourself a specialist and do bigger defects, you have to understand that body mass index is even more important for larger defects. This isn't new. This was published in 1928 and is a presentation from the American College of Surgeons talking about loss of abdominal mass with weight loss. Also, too, you're getting the fascia closed. People talk about all the fancy tricks to get the fascia closed, and I know how to do a component separation. One of the most important things we can do is weight loss prior to surgery. Ed showed some of this, and now, Katie Schlosser, who is now a competent hernia surgeon going out on her own, and she did great work with us in looking at hernia volumes, looking at subcutaneous volume, looking at abdominal volume. And what she demonstrated in her work is, indeed, just 5 kilos, 11 pounds of weight loss makes a substantial difference in our ability to get the abdomen closed. Another study that some of you may or may not be aware of is we actually put Foley catheters in people and actually measured intra-abdominal pressure when Will Cobb was a fellow. And the difference in intra-abdominal pressure between obese people and normal weight individuals. And if you look at this, and this is just doing an arm curl with 20 pounds. A dramatic increase in intra-abdominal pressure. Sometimes failure of a hernia repair is a physics equation. You just tear your abdomen open. And so the physics of this actually makes sense. And so one of the neat things about this study is we did this in morbidly obese folks, 20 morbidly obese folks, and 13 of them, after their gastric bypass, came back a year later and they served as their own control, demonstrating a dramatic decrease in intra-abdominal pressure. What's in it for me? I mentioned time that I spent in the office prior to surgery versus after surgery. And if you look at this, no complications versus complications, people who develop a complication, a dramatic increase in my time post-operatively taking care of patients in 9 visits versus 2.7 visits in a year. Extremely expensive. Ed showed this body mass index and patients ending up in the ICU post-operatively, either on a ventilator or high flow oxygen. And does it matter? Mike Katzen, one of our residents, presented this and actually published this recently, looking at changes over time. And if you look at our data, this is 900 patients versus 900 patients, and it changes over time. The only real difference in these patients is like we have more patients with contaminated wounds. But if you look at our outcomes, BMI, every point of BMI increases their chance of complications by 4%. So it's not just BMI of 40 that matters. I will have people lose weight in any way I can. If you're talking about your hernia love languages, nobody's going to choose prehabilitation as your love language. Not a chance. What we want to do as surgeons is to do this. Skip right to surgery. What you then are is a technician, not a doctor. I mentioned this before. Whose responsibility is it? The American College of Surgeons says it's our responsibility to do this preoperatively. Surgeons make all kinds of excuses. This is a great article by Dana Tillem. Surgeons know this information is correct. They know it'll improve outcomes, and they still don't do it. And so this is John Maxwell, and he is a motivational speaker and helps businesses. And one of his formulas is effectiveness equals quality times acceptance. We know the data is quality. We accept that it's true. But what you have to add into this is performance. If performance is 0, effectiveness is 0. But I have a cure for you guys. If there's, like in America, if you had a pill, this drug is called Noworkatol. And I told you, you could pay $1,200 for this. One pill for your patient. It'll decrease wound infection by 70%, wound dehiscence by 64%, mesh infection by 74%, and readmissions by 81%. You'd all buy it. But you won't work on BMI. What we have to become is a highly reliable organization. You think about, you know when the last commercial plane crash was in the United States? 11 years ago. The technology, I mean, to land a jet on a moving aircraft carrier, incredible. A lot of smart people in this room. What we have to do is bear down. You have to be a good doctor. I was asked at the European Hernia Society, Todd, what was your favorite case of the year? I was on a panel. Super easy. Woman who's BMI 41, 37 years old, 2 young kids. She smoked. Her husband was morbidly obese and he smoked. I sat down and talked, 2 failed hernias. I sat down and talked to her. She lost weight. She stopped smoking, lost 60 pounds. BMI is less than 30. So did her husband. Did a paniculectomy, fixed her hernia, all that. Fantastic. You know what she did? She prolonged her life by, on average, by 14 and a half years. If you look at the Framingham study and you look at the New York life insurance data, you significantly increase, her husband increased his life expectancy by 17 years. You have a chance. And so as a physician, as a surgeon, I would implore you to use your pulpit, use your podium with patients. When an internal medicine doctor says, you need to stop smoking, you need to lose weight, it's like your mama talking to you. But as a surgeon, you have that intersection, that time with a patient, that intersection with a patient that you can take advantage of or not. How many times have you said, as hernia surgeons, do you have a chance to save a life? When you save someone's life, you run out in traffic and save them, you don't prolong their life forever. You just prolong their life. I would say that, like, you can do abdominal reconstruction, or you can reconstruct lives. And that's up to you. Thank you.
I would like to invite our next speaker, Sharon Bachman from the Innova Health System, an expert in complex abdominal wall reconstruction, to deliver the talk on acutely incarcerated hernia in the patient with morbid obesity, best methods of repair. Welcome.
Well, thank you, Jorge, Marina, and Archana for inviting me. I do not thank you for slotting me after Todd, because he is always an incredibly difficult act to follow. And that is him, not me. So I think what Todd just said is incredibly powerful. And we've probably all found that, you know, for patients who really want an elective surgery, holding that over their head to help them with behavior change can be a really powerful tool. These are not my slides. But sometimes we don't have that option. Sometimes the patient comes in, they're too symptomatic or worse. So we need to think about what are our options when we do have acute issues. And I'm going to try to keep this to kind of mostly technical things. We've seen some incredible images so far from some really talented surgeons on some really bad hernias. I have no disclosures. And if we had walk-up music, this would be mine, right? This is a tricky scenario. These are hard. It's never easy. And I think at the beginning of this, you have to ask yourself a couple of questions. Do I have to operate right now, right? Even being able to hold off for 24 to 48 hours can give you more options, but sometimes you just have to go, right? If someone has dead bowel, you're going in. And so you have to really keep in mind in this situation, what is my goal? Is my goal to fix a hernia, or is my goal to get in, do what I have to do to save the patient's life and get out? So we'll kind of talk about what some of those choices are. How often do we have to do this? There's a little bit of data. Sometimes it's hard to sort out this information in patients who are morbidly obese. This was a group of 86 patients from Australia who had irreducible obstructions or strangulations, and they looked to see what kind of complications the patient had in the first 30 days. And so in this group who had a mean BMI of just about 40 and other problems, like we just heard, actually a shocking number of this, it was just plain umbilical hernias that had become symptomatic. Also some incisionals and epigastrics, and most of these were a first-time repair. In this group, I think because they were worried about bowel complications, they really didn't attempt laparoscopy. And in about 40% of the patients, they used mesh, and the other 60, they did not. And not surprisingly, given the data we've seen, there was a very high postoperative complication rate, and most of it was soft tissue. When they looked at the patients and compared patients with a BMI over 30 to not, there was almost double the rate of complications, and they were more likely to be sicker. Although interestingly, it didn't hold out on a multivariate analysis, but still they did find that there were some differences, but none of them were significant. So we've seen this already, but I think it's a really important concept to highlight, which is not all morbidly obese patients are the same in terms of their geometry. You have your kind of classic android with a lot of intra-abdominal fat. You've got your classic gynecoid where you have a small person inside a wider circumference. And then you have some patients who are a mix of the two, right? So I think we've seen versions of this CT, it's pretty familiar. And Todd has already shown some of the data that Katie Schlosser put together and when she was in the lab, and she really did some excellent studies. And one of them was characterizing some of the differences between men and women with high BMIs, right? So it's even within this population, there's different outcomes. And when they looked at open ventral hernia repairs, they found that women tended to have a higher BMI, and measuring their body on CT scan, they had a lot more subcutaneous adipose tissue compared to the men. So therefore, the ratio of the hernia volume to intra-abdominal volume is higher because the actual abdominal circumference is smaller. Whereas men tend to put their extra weight inside the abdomen, that increases that diameter. And so you tend to see larger sized hernias, and you tend to see they need a higher rate of component separations to get across and to bring that together. So whether you do open or minimally invasive repairs, I think laparoscopically, a lot of us in these patients will do an optical trocar technique. And it's really important to keep in mind, how thick do you think that abdominal wall is when you're getting in? You might need to go really slow on those men where it's a really thin abdominal wall and you're in really quickly. Port placement is also important, right? You have much less of a working distance in that patient with a small intra-abdominal volume, and putting your port too close to that hernia can really mess it up. Also, not having your angles be good is also more significant in that patient with the smaller intra-abdominal volume, larger volume of extra abdominal fat, because a small difference on the outside leads to a big distance change on the inside. And then finally, just keeping in mind your the intra-abdominal area you have to work with. When you look at your AP and your transverse, those are very different distances. So you're going to have a much smaller working space in that gynecoid type patient, but also maybe kind of a smaller radius to close versus the larger patient. And then keeping abdominal wall compliance in mind is also, I think, a big characteristic. You can also have a much shorter distance to your target. Again, like we were saying, you can see how the rectus is really thinned and stretched out in the patient with more intra-abdominal volume. So it's interesting that visceral obesity really is a predictor of some of your complications. So sometimes just BMI isn't as important as where the extra fat is. And this was an interesting study that was done in Denmark, where when they compared the visceral volume between patients with similar BMIs, they saw, well, number one, as your visceral fat went up, you were more likely to be male and have a higher BMI, and that defect size increased. And also when they looked at complications, it was a higher rate of recurrence in the patients who had increased visceral fat, increased pressure on that closure. And Todd just showed this, but I really found this paper where they looked at change in weight to have changed my practice recently, because, and you'll see in a moment, that sometimes these patients are going to force your hand. And if you can even just get them to lose a little bit of weight, they found you get the biggest bang for your buck in that first 11 to 22 pounds, right? That change in volume was greatest. It gives you a little more room in that first 10 or 11 pounds. And so if you can just get a patient down, maybe not perfect, but enough to give yourself a little more room. Following these patients, a certain percentage of them here in this paper, 8.3, are going to come to surgery emergently, right? You're trying to manage them, trying to prehabilitate them, but some are going to fail. So what do we know about that? Well, we want to consider what's important operatively. So I tried to break it down into kind of how I think about this case, right? Is it elective? Well, if it's elective, you can try to take your time, you can prehabilitate, you can do your best repair with synthetic mesh and component separations or MIS repair. But if it's urgent, emergent, again, you got to say, am I going in to save bowel? Am I just fixing the immediate issue, or can and should I try to fix the hernia? Taking into account that intra-abdominal volume, again, your port placement is more forgiving in the patients with more more visceral fat. And again, you might need to do a TAR in those patients versus the more challenging placement for the patient with the increased subcutaneous volume, but they have a smaller diameter to close. And they also tend to have more need for paniculectomy. Hernia size. Sometimes it's that smaller size, right? That 3 to 7 centimeters that gets you into trouble. And those you can potentially close. Also the location, is it someplace in the midline or, oh, thank you so much. Or is it that off midline? So Sean's gonna go through really your algorithm, but when we look at, again, looking at the defect itself, in this paper, they showed that thinner patients with big defects did better with an open repair, less complications. Whereas your patient with a high BMI and a small defect, your risks decreased when doing a minimally invasive procedure if you can do it. And the exchange here is with the open, you have maybe a higher infection rate, but with the laparoscopic, a potentially higher seroma rate. Other things to think about, is this a clean or contaminated case? So if you get in there and all you find is tightly incarcerated omentum, you might be more likely to use a synthetic mesh and do a destination repair versus if you're resecting bowel. So I think in that emergent patient with a large defect and a loss of domain, all you're trying to do is not burn any bridges, right? You're going to explore them, you're going to lyse adhesions, you're going to resect bowel if you need to, and then do what you need to do to get them closed. And this might not be the scenario where you want to put in a synthetic mesh or do a component separation. You want to save that for another day. You and the patient know you're going into this with potentially another operation in their future. You just want to get in and get out. Sometimes you might just close skin. You might just close sac on top. You might put a bridge with a biologic. You just want to be safe and get out. For acute hernias in that smaller but more symptomatic group, this might be where a minimally invasive repair helps you, and you might just need to bridge a hernia defect. That might be okay. So here's a patient who comes in with this symptomatic, nasty looking ulcerated hernia. You don't want to be doing an open repair on that patient because of the contamination. And here's where a laparoscopic repair might just be okay. You know what? It's a relatively small defect when you get in there. It's going to be tough to close it. All you want to do is get that defect covered so they're not going to incarcerate or strangulate again and get out. And it's a little tough, but you can do it. So we talked about this, but optical trocars, I think most people will use an optical trocar entry for a patient who's morbidly obese. Going off midline and going up near the ribs where people are frequently thinner can make this easier. You want to avoid scars, and this again might not be appropriate for that patient who really does have an acute small bowel obstruction because you don't have room and you have a high risk of bowel injury. Same rules for a varus needle if that's your preferred method of entry. And again, you might want to just do an open technique and you want to find a spot where there's a thinner abdominal wall. Here's a patient who is increasingly symptomatic, was transferred to my facility because they didn't fit in the CT scanner where they were. They had had this hernia for a while, but it was getting worse and worse, and they arrived with a BMI of 61. And here we've got, the CT scan where there's a lot of stuff in a hernia that's not that big, but you can clearly see that this patient is having problems. So with a laparoscopic repair, we find a 6 by 5 centimeter defect, and then another smaller defect for kind of a total of 12 centimeters. That smaller defect is in the picture above. And it's hard. Like, you have a tight space, and but this would be even harder to repair open. So using a mesh positioning system, some transfascial sutures, you put in a big piece of mesh, 25 by 20 centimeters. And while during some of that case, once I saw this wish scale, I knew I'd lived it on multiple times. It was just good to see it kind of, written out. I was somewhere between a 3 and a 4 in that last case. But you get the patient closed. And yes, there's a seroma, just like you anticipate, and they're going to survive that seroma, right? And I actually, this person clearly had a lot of issues and wasn't very well. So 7 years later, I found in their chart another CT scan. And you know what didn't kill this patient? Their hernia. Eventually, their cardiopulmonary failure got to them. But in this case, an IPOM with bridging did the trick, with enough overlap and fixation. So it's really just deciding what's going to get you through. So again, in a poor working space, you can, for short periods of time, increase your pressure in the morbidly obese abdomen, but you want to make sure you talk to anesthesia about it. Repositioning is going to be everything. You're going to be constantly rolling that person around to try to take some of the weight off what you're working on. And this also might be a scenario for a hybrid approach. I think we all agree that putting in an intraperitoneal underlay is a lot easier minimally invasively, but you might not be able to reduce the hernia that way, and so you might do a combination. For open repairs, you can save some of the sac, save the peritoneum, so that if you need to cover a piece of mesh with it, you can. The retrorectus is a nice space, again, if you think the patient is stable enough. I find this suture lasso, which is actually an orthopedic instrument, a really nice way to pass transfascial sutures because it decreases the rate of stabbing yourself in the finger. So that's a kind of a fun trick I've found. And people do very well with this. So finally, if you have the skills and the patient is stable, an ETEP retrorectus repair is a nice way to do it as well. You're staying out of adhesions in the abdominal cavity. You're putting in a wide mesh. And when they regain their weight, especially in a female, where they're putting the weight on the outside, you can see that this patient didn't recur. She maintained a nice repair, even when her BMI jumped back up again. And I like to mark their linea semilunaris for this in holding and with ultrasound during the case when anesthesia is doing a tap block. I think right now we would say you would only want to do a TAR in an emergent setting very cautiously, and this QC collaborative paper kind of emphasized that. And then finally, I think we've seen a few of these before. These are some of Vedra's pictures, but you can do a paniculectomy with it. For inguinal hernias, again, I think if they're not strangulated, doing this robotically is a great choice on the morbidly obese patient. It's just hard open. And I think we saw the nice hybrid approach from Eduardo just on his presentation. So hopefully those are a few tips and tricks that are helpful. And thank you for your time.
Okay, it's now my pleasure to introduce Sean Arnstein from OHSU, who's talking about decision algorithms in obese patients with ventral hernia, perfecting the outcomes.
All right, well, good morning, everybody. I'd like to thank our esteemed moderators for the privilege of the podium. And before I get started on my talk, a couple of shout outs. One, Yuri Nowitzki, our president, who's just done a fantastic job this last year, really pushing our society forward. And to our president-elect, Archana Ramaswamy, with her and the organizing committee have just put up a fantastic conference. So round of applause for our president and past president. Thank you, guys. All right, and I'll be talking and continuing the theme of obesity and ventral hernias. There's a lot of overlap. We've seen these amazing talks so far, so you can see a lot of overlap with some of the previous talks. Here's my disclosures. I will be talking about some mesh later in my talk, but I've done my best to remove any brand names during it. So preoperative optimization, we've heard a lot about it. It really is an essential part of what we do, given the complexity of the patients that we see on a routine basis. A lot of prongs to that. Clearly, this session is focused on obesity, but that's just part of the equation when we're optimizing these patients and getting them ready for a big surgery. And this is the mainstay of why we want to spend all that time and effort that Todd was talking about. All that investment of your time and energy prior to that surgery is this way you want to avoid is that this so-called hernia vicious cycle where, let's say you take a non-optimized patient, they get a hernia repair, then they develop a complication like a wound infection, a dehiscence, readmission, and then that leads to wound breakdown and subsequent hernia recurrence, and then they have another reoperation, and on and on and on. This is where we have to stop this cycle, and optimizing that patient is the best way to stop that cycle. We've seen this before already by if you don't optimize a patient, these patients have worse outcomes. There's plenty of data to support that. And we know that if we don't optimize these patients, if we don't get them to lose weight, they're at risk for subsequent hernia recurrence, complications as a result of that, perioperative complications, not even just hernia specific. So there's a lot of things that can go wrong if we don't spend the time and energy and effort to get these patients where they need to be. So this is my algorithm, how I take care of these patients. I'm going to show this again later, so you can take some pictures now, but they'll be at the end. It may look complex, it really isn't. It's actually a pretty straightforward of how I manage these patients. Sort of my basic tenets are, one, as we were here, don't burn bridges with these patients until they're optimized, whether it be in the elective setting or especially in the emergent setting. Primary goals, save the patient, save their bowel, save their life if it's an emergent situation. Manage that stuff first, temporize the hernia, and we'll talk about that. The big hernia, the big apple reconstruction, that can be done at a later time. There's a lot of things that we can do prior to that. Talking about emergent ventral hernia repair, looking at this great study, looking at the Danish registry, when they compared emergent versus elective ventral hernia repairs, and you can see those odds ratios on the complications that results when we force an operation on somebody sooner than we need to. Now, some people need an operation in the emergent setting. It happens. But there are things we can avoid, especially doing complex abdominal wall reconstruction, using those golden tissue planes that we want to save until that patient is more tuned in and ready to go. How about watchful waiting? Again, there's data to support, just like for inguinal hernias, for ventral hernias, there's data to support safe watchful waiting where morbidity and mortality is not increased when you compare the standard group versus a watchful waiting group. But there is an expense of it, and that is of quality of life. So it's not all rosy for the patient. This is a tough road for these patients to go down on, but it is a necessary road. So right now, instead of focusing just on data right now, I'm going to go through just a handful of case scenarios to kind of highlight some of the ways of getting and managing these patients. So this first case, this was an obese patient with a multi-recurrent peristomal hernia. And I know what you're thinking. Okay, it's a peristomal hernia. They're all going to come back. And that is true. Most of them are going to come back to some degree. Well, unfortunately, this patient came back acutely incarcerated with a bowel obstruction. So, and this is actually her second ER visit. So when they start serially coming to the emergency room, their body's telling you, you got to go. Now, there wasn't threatened bowel for the first time. This time, there was more of a concern for her bowel. So took her here. And while there are some options for mesh placement and this and that, at this point, the job is to get the patient in, reduce the bowel, save the bowel, primary close it, bring her back at a later time, more optimization, weight loss, and then plan out another subsequent repair, perhaps a definitive repair for peristomal. Second case, you see a morbidly obese patient, huge hernia sac, decent sized hernia defect, but you notice there's that number I put there, the hernia neck ratio of 2.76. In a similar fashion, a gentleman, larger gentleman, weight-wise, BMI-wise, smaller hernia, smaller sac, but look at that number, that 2.67, the hernia sac to neck ratio of 2.67 also has some chronic skin changes as a result of pressure necrosis from this. When it comes to hernia neck ratio, sort of the magical number is 2.5. And they did this based on their statistical analysis to come up with that 2.5. They didn't just sort of randomly come up with it. It's a very simple risk predictor, and it's something you can easily do in the office. It takes like 10 seconds to do just by comparing the diameter of the hernia sac at the widest compared to the diameter of the neck of the hernia defect. And what they found was that if for ratios greater than 2.5, they had a 53 times increased risk, at least for umbilical hernias in that first study. The second study looked at not just umbilicals, but other ventral, incisional, and other types of hernias, but significantly increased morbidity and mortality for patients that had a hernia neck ratio greater than 2.5. So the conclusion of the authors was that if that ratio is 2.5 or greater, consider operating on them earlier. That doesn't mean that every person needs an operation in that setting, but those patients are more likely to require an emergent repair. And so again, if that patient is showing up in the ER month after month or more frequently from a time standpoint, their body's telling you it's time to go. That doesn't mean that you have to commit to a reconstruction, though. As Sharon just nicely showed us, there's other ways to get this patient through it. Assuming that there's no bowel compromise like strangulation or need for bowel resection, these are great for doing a laparoscopic or robotic intraperitoneal underlay mesh. If you can close the defect, awesome. Those are better repairs. But in an emergent setting, if it's a large defect, bridging those hernias, getting that patient out of Dodge, saving their bowel, that's the priority there. What about other, I would call even more challenging scenarios? And these can apply to not just obese patients, but certainly obesity adds another layer of complexity to it. So infections, things like infected mesh, chronic draining sinuses, suture abscesses. There's a lot of this is wound care. So managing that's a quality of life issue right there. You can suppress them with some suppressive antibiotics just to kind of cool that infection down a little bit. You're never going to eradicate that infection until they receive excision of all that foreign bodies. But also, even though we might need to operate on these patients sooner just to get rid of get source control and get rid of the infection, doesn't mean we can't offer other optimization strategies. We still want to get them to stop smoking, get their A1C down to a reasonable level, because at the end of the day, this is all about wound healing. And if they're having other factors that impair wound healing, you need to address those ahead of time. But at the bottom, you see that plus or minus weight loss. While it would be great to get these patients to lose as much weight as possible, a lot of times you just have to go to the OR, take care of all the sources of infection, because when they have an active chronic infection or a fistula, this is a hypermetabolic state. It's very, very challenging to get them to lose weight successfully. So we can still do weight loss, but that we're going to save that for down the road. So initial management of this surgically is wound exploration, and you really got to get rid of all foreign bodies in there. Tacks, sutures, mesh fragments. Read those op notes to see what type of meshes were placed in there, what tissue planes were in there. Because invariably, if you just remove only what you see in front of you, you know there's going to be mesh hidden within those tissue planes out laterally. And if you miss those, they may look great for a couple weeks, for a few months. They may come back with another chronic draining sinus, and you're going to commit them to another operation just for source control. So spend the time really digging deep into the abdominal wall and get rid of all sorts of permanent foreign bodies. And then we're going to temporize that hernia. That might mean just primary suture closure or perhaps a mesh bridge of some form. And I'll go over a little bit of that. Save that abdominal wall reconstruction for a later time when there's no source of infection and when they're better optimized. Fistulas, similar. I mean, you're going to see the same kind of thing because the algorithm is the same for these. You're saving the patient. You're going to take down that fistula eventually. But fistulas are their own kind of special beast. They take a lot of management, and when it comes to quality of life issues, infected mesh and fistulas are up there with some of the most challenging things for the patients. Some of the initial mainstay treatments for fistula management is nutrition. If they are, and it doesn't matter obese or not, Eduardo pointed this out, how obese patients can still be malnourished. Send them to a nutritionist, whether they can take enteric nutrition or maybe they need TPN. Get them to a specialist to help them optimize their nutrition so you can have successful wound healing following the initial operations. Wound care, we have access, at least at OHSU, to great wound people. Our ostomy nurses are amazing magicians on doing wound managers or ostomy appliances specifically for fistula management. I know not everybody in the community has access to those folks, but if you do, they can be lifesavers for helping that patient's quality of life and protect their skin. And I think that third bullet down at the bottom there is probably the single most challenging thing for the patient, and that is time. Fistulas do not get fixed immediately. it takes typically months and months to get them nutritionally optimized, to get adequate wound healing for this. So this is part of that time, as Todd pointed out, in the office. It's counseling. It's making sure they realize that we're in here for the long haul. This isn't a quick fix. It's going to take months, perhaps years, to go from when I see you in the office for the first time to when we're done fixing your hernia with a reconstruction later down the road. And same thing, these are bowel resections, so we want to make sure we're getting smoking cessation to minimize leaks and other infectious complications, as well as getting their diabetes under control. So just like with the infected mesh, we want source control, debride any devitalized and infected tissue, do whatever necessary bowel work and anastomosis and resections that you have to do, and then again, temporize that hernia, don't burn the bridges. This is one example of a gentleman. His BMI was about 47 at the initial visits. We actually got him to lose a little bit of weight. He was luckily not a non-smoker, and we got his A1C down to a reasonable level preoperatively. We did a fistula takedown, debrided this skin, and bridged this with a human cadaveric dermis, and really optimized his nutrition throughout that whole pre and postoperative course. And then by 7 weeks, so a couple months after this operation, his wound is pretty much healed. Unfortunately, this gentleman started to gain weight again, so we're still in the phases of going back to the original things about optimizing, get him to lose his weight, and then we're now going to be planning out his definitive abdominal wall reconstruction. And then the last case for you is a pretty challenging case. Gentleman was a BMI of 48. His A1C was bouncing back and forth between 9 and 10. You pull up your CEDAR calculator, and he's 84%. This guy, doesn't matter what you do in him, he's going to have a wound complication if you take him right now to the OR. Also had 3 prior repairs with various meshes inside his abdomen. So this is him. He luckily had a good wound care center near him in somewhere in southern Oregon. But look at those ulcers. I mean, this is not a clean case. Even if we had to go right now, this is at minimum of a clean contaminated case right now. Extremely high risk. So we optimize him. We were watchful waiting with him for a while. In fact, over 2 years, we were optimizing him. And part of this was there were some logistical challenges with him coming up to Portland to get this done, but we still were following up to him. But after 2 years, we got his BMI down with just medical weight loss. We got his A1C down to 5.2. That might be lower than mine. I mean, he did tremendous work there. And this was all self-directed with a lot of counseling and a lot of assistance from us and our team. But there's a consequence for some of this waiting. Yes, he lost weight. Yes, he got his diabetes under control. But one of these ulcers led to a fistula. So now we have more problems to deal with than just a handful of skin ulcers. So again, staged approach. Stage 1 was going in there, wound debridement, took the fistula down and anastomosis, bridged him with a biologic mesh at that time. And then he continued to lose weight, he continued to do well from an optimization standpoint, and he got a definitive repair with a TAR, with macroporous polypropylene. So, it took a long time to get this done, but this is a good success story, but it took a lot of time and effort on the patient's end and on the surgical and medical side as well. So I know I talked a lot about temporizing hernias. There's some good ways to get these patients to stabilize their hernias before committing them to the reconstruction. And while there are things like closing with skin, and other sort of techniques, I do worry that when that bowel is stuck to the subcutaneous fat, that's going to lead to severe adhesions when you have to go back in your repair, or perhaps fistulization, even worse. So I'm a big fan of bridging these. We want to prevent evisceration and minimize adhesions, and perhaps even downgrade that hernia. So maybe they come in with a 15-centimeter hernia at first. You can do some primary closure, tighten that up a little bit, maybe convert that to a smaller hernia that may change your subsequent operation, maybe not needing as complex of a repair knot. There's 2 mainstay ways of bridging this. There's a bridge inlay. That's where we're just sewing edge to edge to the mesh, or a bridge underlay, which typically is more overlap, but does require a lot of transfascial fixation. So there certainly are pros and cons to each of these, but I would say I favor a bridged inlay because that's the quickest and the easiest. You just sew edge to edge there. You also doesn't require extensive adhesiolysis. It's nice to make sure we clear up the abdominal wall, but if somebody has sort of a socked-in abdominal wall from whatever intra-abdominal disasters they've had in the past, that can be challenging. You can avoid that just by clearing up a little bit of fascia and sewing edge to edge with your mesh. And there are multiple mesh options for this. I prefer either using a P4HB mesh or a human cadaveric dermis for these. Again, both have their pros and cons. This is not a mesh lecture. I'm happy to talk to you all and geek out on some mesh talk afterwards in the backside if you want. But there are other alternatives. If you want to do a true bridged underlay with bigger overlap, you can use a thicker biologic mesh like a porcine dermis. Vicryl mesh is really fallen out of favor. It has way too rapid of an absorption time with only a few months. And when we used to use this back in the day, we're actually seeing some rapid recurrence of the hernia. So we've really gotten away from using vicryl mesh unless we're patching little holes in the posterior layer for reconstructions. And so coming back to this slide, just again, don't burn bridges, save the patient's life, save their bowels, come back to fight another day. And if they're already optimized, your job is easy. You're just talking about the procedure at that point. You go through the steps of getting them their repair, whatever they need. But if they're non-optimized, there's a couple paths you can take. That does differ, whether if it's an emergent case or an elective case, but the themes are the same. You're managing that patient, you're temporizing the hernia, you get them optimized at a later point, and you come back to fight another day. So to conclude, preoperative optimization really is a key aspect for successful abdominal wall reconstruction in a lot of our complex patients that we have. We talked about temporizing these patients, and really trying to also avoid abdominal wall reconstruction in the emergent setting. I know there are some studies that show it can be done, but just because it can be done doesn't mean it should be done until they're fully optimized. And so I'm just going to skip down that bottom thing. Is one of the crucial things, though, is these patients need follow-up. It can be challenging. We have patients from all over rural parts that can be difficult when they get lost to follow-up. But you need to survey them. You got to track them along to make sure they're doing well. If you just tell the patient to lose weight, stop smoking, even if it's a great counseling session, if you just tell them that and don't have follow-up at 3 months, at 6 months, or whatever intervals you feel appropriate, there's a good chance that they will fail with their optimization. So it takes a lot of input from the surgeon, but it's worth it in the end. So thank you very much, and looking forward to the Q&A afterwards. Appreciate it.
Our last presentation is abdominoplasty and hernia repair, timing and maximizing cosmesis by our friend Miguel Ángel García Ureña from the Hospital Universitario de Henares in Spain. Welcome.
Thank you so much, and thanks so much to the American Hernia Society for giving me the opportunity to be here with these kind of experts. And I don't know what I'm really doing here because I'm an hernia surgeon, not a plastic surgeon. I feel that I'm stealing the plastic surgeon's talk today. And my children like surfing and likes these waves, and I try to compare complex hernia with waves because they like the waves because there's every wave is completely different to the next one, and it's always happening with complex hernia repair. So after showing you my disclosures, I had to tell you that I came to 10 years ago to learn posterior component separation from Alfredo Carbonell, and I have already made over 500 patients. But I'm gonna tell you my perspective of a hernia surgeon, a general surgeon. I'm not a plastic surgeon. I think that when Real Madrid will sign Mbappé, I think this is the time my hospital will sign a plastic surgeon. So it's still time to come. So it's true that maybe we need to perform an associative pancreatectomy when we are dealing with complex abdominal wall repair. And Chopra and Sain, in this nice chapter of the Novitsky book of hernia, they differentiate paniculectomy from dermolipectomy, but I have to tell you the truth that being practical, this is quite very difficult to differentiate what you are doing if you are only removing skin or redundant skin, or you are also taking out subcutaneous tissue. So apart from the evident aesthetic benefit of the repair, there are also functional benefits regarding we're going to improve the mobility of the patient, we're going to solve hygiene problems with the skin, And also has been demonstrated that the subcutaneous tissue make like a still phenomenon because of the increased perfusion of the subcutaneous tissue. So what are the main indications to perform a paniculectomy? Of course, the excess of skin, problems with ulcers, rashes, infection, mobility, massive localized lymphedema, all that stuff. But what I like is to take out these pounds there hanging on my beautiful retromuscular repair. So that's one of the reasons to perform also a paniculectomy. And it's all, again, about anatomy. I think it's so important to know the basics, principles of the vascular supply to the skin and subcutaneous tissue, and to have these three zones always in your mind, because many of the patients have a lot of previous surgery. By example, this man had to operate in the north of Spain to help them with this case, and the first index operation was a simple epigastric primary ventral hernia. And after 9 unsuccessful repairs, including a kidney transplant over there, we had to manage this patient. And after 8 hours, we didn't have plastic surgeons around, and then we had to make this fleur de lis. But please take a close look to this, to the repair, and you can see here the scar over there, a lot more lateral scar. So what happened? This what happened. So this is something that you have to bear in mind always, that because it was a very long operation and we didn't realize this scar, but the patient did very well, but it took him 4 months to solve the problem. So we do have complication if we combine abdominal wall reconstruction with paniculectomy, and this has been reviewed in this systematic review. It's a very nice systematic review of all the papers published about the combining hernia repair with paniculectomy, and there's a lot of high rate of surgical site occurrences. And you can see here in this diagram on this paper that the mean was 30%. I think it's really low, but there are some series with almost 80%, with even 80% of surgical site occurrence after associated paniculectomy. And in this very interesting study from Fisher, that he reviewed the NSQIP database, and you can see here that the paniculectomy was associated with more wound healing complication, more unplanned reoperation, more thromboembolism, and more medical morbidity. And also in this very nice paper from the group of Todd Hennifer, that they analyzed their experience with more than 1,800 patients, and still paniculectomy is one of the risk factors of wound complication. And you read the discussion, so interesting always, the group of Hennifer's discussion. He came also to the conclusion that comparing the first 8 years to the last 8 years, they are now making fewer concurrent paniculectomies in the last 8 years, probably because they are also becoming aware of the importance of the complication associated with paniculectomy. So what's my plan when I try to deal with this patient? That first of all, be sure that it's indicated a paniculectomy. I think that because you are going to edit these risk factors. And also, one of the principles, please make it at the end of the operation. Please leave everything, skin, scars, everything until the very end of the operation, because you don't know what's going to happen in the surgery. And you may have surprises, and also you may need the peritoneum always, and it's so important, has been already remarked by my previous speakers, to save the peritoneum as much as possible until you don't need it anymore. So let me show you some images of cases, and this very big, this is early in our series. I think this patient we operated in 2013, and you can see here that we made just a simple first incision. We then have to deal with the abdominal wall reconstruction. I want to remark here that it's important that when you remove this big sac from the skin, you're going to have problems with the skin. Also, you're going to make ulcers, you're going to open the skin. So you have to deal with all that stuff performing a paniculectomy. It's true that it has been said that the paniculectomy is like an intuitive surgical endeavor, but I have to tell you that I was educated in Cartesian rationalism. So I try to rationalize all my procedures. So what's my plan when I want to make panniculectomy? So I try to divide in vertical, horizontal panniculectomy. If I have to take out adipose tissue, then I will perform horizontal, like Spadafora described, or fleur-de-lis panniculectomy. I'm gonna try to show you some cases with some video recordings, and you can see here this is a very big scar there in the middle. Leave it until the end, you know, because when you have already performed your posterior component separation, this is a small breach over there. You can see here. You can now decide how much you can take. Probably in this patient, particularly in this patient, probably skin expanders could have been a very good idea before planning the surgery. Always learning. And this also very big incisional hernia. We optimize the patient, of course, with also adding Botox and pneumoperitoneum. And you can see again, the first thing, the first principle to make the midline incision, solve the problem. And once you have performed the abdominal wall reconstruction, just remove your skin, your redundant sac that you don't need anymore, as you can see here. And in this vertical panniculectomy, we also added a little horizontal in the inferior part of the dissection. You can see here that we are trying to spare as much as subcutaneous tissue as possible. And you can see here that we made like a horizontal incision to perform and to get better aesthetic results. And you can see here in the long term, this patient, again, we change his quality of life. And that's so an important thing that to consider. Also in this patient that we operated 3 weeks ago only, less than 3 weeks, and it's a very big one. And what the hell I'm gonna do in this patient? You know, it's my first intuitive thing. But we finally performed a retromuscular peritoneal with a bridge repair, and you can see here that at the end we had to remove some, of course, this vertical panniculectomy associated during this semilunar disruption. This patient was very tricky. Also 9 hours of surgery, kidney transplant. Also hanging on the there. It was quite amusing. So, but you can obtain good results. This is 7 days after the operation, and of course, it must be like a palliative surgery. But we were even planning to perform a complete panniculectomy in fleur-de-lis, but we thought that it's a very high-risk patient. I was not worthy to do it at all because we are going to edit more. So you have to balance that, you know, when you are dealing with this patient. Probably my technician part of my soul would say, okay, I'm gonna perform a more beautiful and remove all that, but I have to pay a lot for that. So I think that that's so important message. In this Marfan syndrome, you can see here that we also had to perform at the end an oblique panniculectomy. You know, the patient had a previous myocutaneous flap over there with several attempts on repair with a total replacement of the aorta from the heart to the femoral vessels. And also in this kind of subcostal after liver transplantation of pancreatic surgery, they are quite tricky also. And it's quite tricky because in the superior part of the sac of this patient had a debilitating external oblique muscle aponeurosis. So if you remove your sac in the superior part, you're gonna remove part of your repair. So that part over there is part of the external oblique muscle. You can see here that at the end, we decided to perform the horizontal panniculectomy. And you can see here that 2 years later, we obtained such a very good results dealing with this kind of surgery. And finally, horizontal panniculectomy, we can also add in some cases and scenario. This is a combination of midline and lateral incisional hernias with this subcutaneous tissue over there. And after optimization, the patient, you can see here that what we are going to make is to mark our line of incision of the panniculectomy, but with the lower horizontal incision, we made all the abdominal wall reconstruction. And then at the end, we finally made the Spadafora technique, and then we cut the midline. It's so easy to do that way and remove the cysts of the skin. And you can see here that we are not plastic surgeons, but we are learning to make it better and better. And finally, for example, this patient, you have to plan a fleur-de-lis because if not, it's going to be impossible. So mark your lines before the operation. forget about removing anything, sac, skin, and the very end of the operation. In this case, it was a very M1, M5, so we need to go up, and then we made a middle incision, and at the end, we decided to make this vertical paniculectomy associated with the horizontal. So at the end of the operation, when you decide the vascular supply of the skin and also taking care of the previous lateral incision, and this is the horizontal there, and the iliac incision over there, and we are almost here finishing our paniculectomy. And you can see here that we can obtain excellent results just following plans. No, the plan A is just perform your surgery and at the end make this nice reconstruction of the skin, and have also quite such a good, very good results. And sometimes you have to adapt yourself. No, you have your plan in your head, but sometimes you need to be intuitive. So in this kind of patient, what we did, sorry, I was trying to point out, we take the lateral subcutaneous tissue, we made like a transposition of the lateral subcutaneous tissue to the midline to try to close everything, and that's what we did. And it was only, just following what we could do. Finally, sometimes you have to make, has also shown this morning, an asymmetrical fleur de lis in this patient. You can see here that this is what we did in this particular patient. So finally, to conclude, I think that paniculectomy could be necessary, but it's significant morbidity. Only perform it if it is necessary. Watch out, previous incision, because it's going to impair your repair. Solve the defect first, solve the problem, and use your peritoneal sac as much as you need, and remove it at the end of the operation. Apply the basic principles of vascular supply, draw your lines, and please have a plastic surgeon if available. So thank you so much for having me the opportunity to be here sharing our experience. Thank you so much.
Anyone in the audience have questions, please come up to the mic. And is anybody coming? Okay. So then I have a million questions. How many people in the audience actually do medical weight loss for their patients before the hernia? I mean, do you do it yourself, or do you? Yeah. Okay. Good. And one of the things that I think is so interesting is I get patients from my general surgery colleagues, because they know I do medical weight loss, and I can get patients to lose like 50 to 70 pounds before surgery. Those are patients I would have liked to operate on, but instead I'm just getting them ready for their hernia surgery, and that's okay. But I mean, I think it's really important, if you don't have it in your practice, that you find someone who can do it for you. Can you turn the mic? No. Any one of you. What? So is it, how much is significant? Like, what do you?
Would you like me to repeat the question?
Yeah, just one. Is it 10 pounds? Is it, what are you actually seeing when you try to get them to lose weight?
Well, it varies from one patient to the other, but there's a significant amount of patients that they may lose 5 pounds in 3 months, and then you see them at the 6-month mark, and they may regain the weight, then they lose a little bit. The question, I don't know, do you see that in your practice? Do you see these patients who just don't lose weight? And what do you do with these patients?
I'll start. The majority are not successful. Even if you try to stick, there's a lot of issues here. One is economical situations that, and the other one is insurances. The next part is how much symptoms are they having, and is they're coming into what Sean looked into, this vicious circle. Sometimes you start and then you start going and they're not getting optimized, and they're getting worse, and then you have to decide if you gotta take them with what you have, because they're not gonna get any better. So I think you have to individualize this case, but again, I agree with you. A lot of these patients most likely will not lose what we need to get them below 35.
And what do you do if they can't lose weight?
So you try everything you can, from nutrition, from pharmacotherapy, to surgery if you can get them. But if they can't get to it and they're asymptomatic, I'll take them to surgery.
I think you do the best with what you have. So a lot of it is you set them out, give them a program for a month or two, have them come back and see if they're having success, right? And for as long as they can tolerate their symptoms, you try to go. And if they haven't lost to your goal, if they've even lost some, I think, again, that's where that paper from your group, Todd, has kind of opened my eyes to, we might not get people perfect, but if we can at least get them to lose something, that first jump is the biggest bang for your buck. And if they're now increasing their exercise and their cardiopulmonary tolerance, I think that's a big part of it, right? I think we underestimate how much just getting them out, getting them walking and maybe more active than they were previously can help them tolerate surgery better. But it comes to symptoms.
So I'd sit down with the patients and I would set a plan. And I described to them why it's important to lose weight. Wound-related complications, absolutely. The other consideration is like, what are our goals is to get your fascia closed. That is the most powerful tool that I have to get your fascia closed. And bigger defects, and we see a lot of big defects, of course, is weight loss is first. But we do chase them. I used to, and again, Katie Schlosser's work, we found that if you follow patients, so watchful waiting for ventral hernias when you have a long incision is a non-starter. Because what will end up happening is, for smaller defects, when you don't, and there's not a laparotomy incision, those hernias don't get a lot bigger real quickly. But for a laparotomy incision, when you have a moderate sized defect, if you follow those patients over 18 months, you increase the average size of that defect by 80 square centimeters, and you increase the volume by 1,500 cubic centimeters. And so she changed my life. Katie done a great job. And so I tell the patients, this is what we need to do, and it's not an emergency or an urgency that we operate on you. We have to set a plan, and we want to follow you. So that's why we call, and I become their cheerleader. I'm not gonna browbeat them. I'm not gonna give them a hard time. But we have to set goals to decrease. How many patients do I see in my office that started off with a morbidly obese patient with an umbilical hernia, and 7 failures later, their hernia is this big? I'm not gonna push that patient down that rabbit hole. And so, there's nothing perfect, but I will tell you, like medical weight loss now with Ozempic is amazing.
Manjaro's better. But
Yeah,
the other thing what you're saying is it's follow-up. You said, and then 3 months later, they didn't lose weight. I bring those patients in every month that I'm medicating for my colleagues, but they come in every month. And yeah, that's my time, but it's because of their accountability, they're coming in, I can adjust their meds, or I can at least discuss with them what they're not doing. So, when Todd put up this stuff about calling them, I started thinking I need to call my patients more, but for real, that really is going to make a difference because that engages the patient more.
So one of the things that I also do is I actually tell them about my weight loss. And I tell every single person that needs to lose weight, I talk to them if they can go on a ketogenic diet, just like if you made me eat birdseed and cardboard, I would never lose weight. 14 years ago, I lost 44 pounds in 11 and a half weeks. I had a patient challenge me. She's like, well, if I've got to lose weight, what about you? And I weighed exactly what I weighed when I played college football. I had not gained a pound, but I lost muscle mass. And so I tell patients, this is what I did and how I lost weight. And does a personal, I think telling stories to patients, to anyone, improves understanding. And if you show your own, like I don't know what my body mass index was, but I tell them, this is the way I did it. And I sit down and I just and I just describe a ketogenic diet and how it works and how sugar affects like how you hold on to fat. Because like I mentioned, we're waiting for wintertime. There's no more wintertime in the United States.
And just,
I make it personal.
you know, to echo what Todd was saying, a lot of this is on patient counseling. And it goes back to what I was saying, it takes time and effort. It really does. It takes a good chunk out of your practice to do it. And, if you have support staff, nursing staff or APRNs or somebody else that can step in and fill that role. And, we'll bring them back 3 months, 6 months. We'll set some goals. Sometimes we have to readjust what that target goal is. Though I don't believe that zero weight loss is a thing. I think every patient has the ability to at least lose some. They may not be as effective losing as much as I'd like, but there's also, do they have the adequate resources, whether it be nutritional standpoint? Surgical weight loss is very challenging from an insurance standpoint, which is unfortunate. Hopefully with the medical weight loss therapies that have been on the market now and upcoming can help facilitate that. But again, there's an insurance struggle and access to care like that. But got to get that, the patient has to have some buy-in. And that's where that counseling session in the beginning of the stages of your talks, it helps out. To empathize with them and tell them, we'll get you there. I'll help you along the way. I'm going to do my part to help you out along the way. You got to do your part. There's a cooperation and ownership on the surgical standpoint and on the patient standpoint. And sometimes that's a delicate dance. You got to walk with them. It can frustrate the patients. Again, it can be a challenging situation. The patient is going to cry, walk out the office. But you're going to follow up with them, and you're going to try to get them on track. It's not always an easy situation, but I firmly believe that all patients have the ability to at least lose some. You just may have to readjust your targets down the road.
I really like what you said, because I think my concern when I brought this question is that preoperative optimization is really designed to get the patient to surgery and to get them there safely. And I worry that sometimes if we stick to these rigid goals that the patients may just not be able to meet, that we're shunting, we're basically shutting patients out of access to care. So I think readjusting the target, if the patient has actually demonstrated they have buy-in and they really tried all their effort, I think makes a lot of sense.
You just have to see if the patient's going into a spiral. If the spiral is getting him down, and I get a lot of these that they've been going from doctor to doctor to doctor. And again, we have to accept that, otherwise we weren't doing bariatric surgery. A lot of these patients don't make it. They just don't. With counseling, whatever you want to say, they just don't make it. But you have to see if you want to grab them down when they're digging a hole, you want to grab them up here. That's why you have to individualize each decision.
Your paradigm is shifting, right? If you look at what you're doing in hernia surgery, foregut, it's gone from, I did an inguinal hernia repair, just come if you're having a problem, to I want to see you in a year. I want to see you at 6 months. And that I do with my foregut patients, and obviously I do it with I have to with my obesity patients. So that once you bring them back, that really holds yourself accountable to your recurrence rate and everything else. Thank you so much. Other mic.
Thank you, the panel, for an awesome presentation and sharing your interesting cases. This is Sharon Schraga from the University of Southern California. I think one of the panelists brought up an idea of visceral reduction. It's an idea that I had attempted or thought about often intraoperatively. I've never done before. I want to know what's your experience on visceral reduction? When did you decide to do it? What did you take, and how much do you take?
Okay. I just want to disclose, I've been sued by visceral reduction. Okay, just to start with that. These are patients that you saw the amount of tissues outside, and this has to be disclosed with the patient very clearly. Things doesn't go in, you have a very high risk of having intercompartment syndrome, and you have to explain that to the patient what that means and how things go. And then you say, hey, there's some things in these obese patients that they can, give us some space. And to make it simple, omentectomy is the easy one. So you can have a lot of room, you can take the omentum out. Somebody has a, non-childbearing, you can have a very large uterus, and if something you can, that's as well as indicated. And then you start to get, what can you take? Then you get to bowel, okay? And then usually what I take, I try to take the right side if I can and go the other way until it can get the space. It depends if how many bowel movements they have or what are the conditions. So you have to choose between right and left. And that's pretty much it. In this patient, I took the right side and I take as much of that down to the mesentery that I can to make as much space as I can. But this is a controversial issue. There's another surgeon in Brazil that does these as well, and we do it in extreme cases.
And when you say right side, the right colon, you mean?
Yeah, it depends. You know, if the patient is having, let's say, how many bowel movements you have a day? Oh no, I'm constipated. You know, I have one bowel movement every 2 weeks. I'll take the right colon. That's where the absorption, you know, is. If the patient is having issues with not as they have a very frequent bowel movements, I try to go to the left side.
Thank you.
I have a question for the panel. If you are going to operate a patient on a sleeve gastrectomy, especially for Eduardo, who does also obesity surgery, and the patient has a central defect of, let's say, 6 centimeters and without content, what would you do to the defect during the bariatric procedure?
How big is the defect?
6, no content.
Okay,
No,
that's fine.
no content.
So, you know, I think that, I'll tell you what I do. If it's a fat and it's omentum, I try to work around it. I'll leave the fat inside. And then I try to leave it. There's data suggesting that
It's empty. It's empty. No content.
You have nothing.
Yes.
Okay. Then, you know, you discuss with the patient the pros and cons, and this is a case that if I think something's going to strangle it, I can just do an inlay and then wait for the weight loss and then come back later.
Oh, thank you for the panel. Some lectures. This is a question for Dr. Garcia Ureña. Some plastic surgeons recommend in postoperative surgeries the use of compressive regardless. And do you have some experience with the use of glue in this kind of patients to avoid seroma and bleeding?
Sorry, I try to use kilted sutures to avoid. I don't have experience with glue yet, but I prefer to try to suture as much as possible the subcutaneous tissue, approximative scarpa fascia, and drains. I think that in this particular patient, I think drains are the main thing. And regarding the binders, I always try to advise to wear binders at least in the first months, but not lying on the bed. I think that there's no need, but when sitting down or starting to walk, I think they help a lot, of course. And I think that the external pressure of the binders to the subcutaneous tissue, I think that's quite a good thing to do also.
How many times do you let the drainage in this patient?
There are 2 kinds of drains in this abdominal wall reconstruction patient with paniculectomies. The drains that are placed between the muscles and the meshes, I try to take them out as soon as possible. When the output is around 100, I will remove them. But in subcutaneous tissue, I will remove it when there's almost no output. I discharge the patient with the drain.
Okay, thank you.
Miguel, if we apply prophylactic WAC, do we really need a subcutaneous drain in that cases? If you apply WAC device for prophylactic manner, do we need to drain?
I think he said putting a wound back.
Vacuum-assisted device to the skin for
Yes. That's I try to apply back, to close the skin with a bag. Yes, I think that there are not enough evidence to use and avoid wound morbidity regarding the protection with a closed skin bag system. I think, like Prevena, by example, I think it's my usual way to go. Yes, sure.
Thank you for the presentations. I'm Tyler Sarback, 4th-year resident out of Corewell Health in Detroit. My question is, what is the longest amount of time you've counseled your patients on weight loss preoperatively? How long have you waited before taking them to surgery? And then what is also your average time that you typically counsel them preoperatively or your goal?
So, I mean, I showed you that case at 2 years on that gentleman. That's unusual. Most patients aren't usually waiting that long. That was a special case. But I would say, without knowing the specific data time frame right now, 3 to 6 months would be reasonable. It depends on what their trajectory is. It also depends, do they need to go to bariatrics? Because that's going to really extend that time frame between the first time you see them and then not only bariatric surgery and then the weight loss following that. So that could be a year plus. But I would say for modest weight loss, probably 3 to 9 months. I usually see them back every 3 months, but we're doing a lot of telephone visits, virtual visits. So, it's saving a lot of time and effort, not dragging them into the clinic, these kind of things. So it really has to be individualized case by case basis.
I think sometimes you can wait longer on people with the big hernia defects, right? The massive hernia defects, they're not going to strangulate through those. There's tons of space. That bowel's been there for years. And if you're worried that you're not going to have enough space to fit things in, you can take the time you need to, go through weight loss and create space. Some of the smaller hernias where you are worried that maybe they're going to incarcerate or strangulate, you might have a shorter time window. So it kind of depends on symptoms and some of the things like Sean showed in his algorithm for, what is that ratio of the sac and the hernia size?
I'll say that it is very common that if people will, and again, I keep falling back to the ketogenic diet because we've had a lot of success with it, but it's very common that in 6 weeks, people will lose greater than 20 pounds. If they'll just go strong on the ketogenic diet and stay away from sugar and that, it's very often you talk to your patient, you'll say, well, what do you drink? Well, I drink 2 liters of Mountain Dew every day. If you explore what they eat and how they eat, but it's very common. You can lose more than 20 pounds in 6 weeks.
Dr. Hannaford, do you see rebound weight gain after?
I think and I will have conversation with patients. When we looked at our failures, and one of the things that we're exploring now is, when we did last year, is looking at what is the anatomy or the autopsy of our failures. We have 247 ventral hernia failures. You're like 247 failures. That's an incredible number. But of those, we have a significant number of the people that have gained a tremendous amount of weight. And so I tell patients, once they've lost weight, if they gain 5 or 10 pounds, it doesn't matter. But once we start to see weight gains, and we have no data for this, but once you start seeing weight gains greater than 30 pounds, then that's when we have seen those patients develop fracture of their mesh and failure of their abdominal wall reconstruction. But that's a great question. And I do have that conversation with patients after they've lost weight.
Last question, Dr. Flavio.
Thank you. For sure, great presentations. I have a final question, maybe Eduardo and Miguel. For sure, no gigantic catastrophic defects, but I often use an onlay plane after paniculectomy. In my mind, the plane is out there. I'm not burning the retromuscular plane on maybe a non-perfect pre-optimized obese patients. So I just want to hear the panel thoughts on, is onlay after paniculectomy okay for maybe smaller defects?
Can you repeat me the question, please, Flavio? Only mesh after paniculectomy. Okay, I think that in cases that I'm going to add an anterior component separation, probably could be not a bad idea to perform an onlay repair. I use a big mesh as onlay, but that's not my usual way to go. No, I always try to place my mesh in a retromuscular position, even if I perform a big paniculectomies like the ones that you have seen in the video. So I try to escape the mesh from the subcutaneous tissue as much as possible. It has been demonstrated more surgical site infection, more surgical site occurrences. So I try to avoid the onlay mesh, yes.
But the surgical site infections is because of the paniculectomy, it's not because of the onlay mesh.
Yeah, but it's not only a factor, it's the combination of factors that may make the wound morbidity. No, so if I can remove a factor, I will remove it. So And you have seen some of them has been bridge repairs because it was impossible to completely close the midline. So another matter of discussion would be, should that add an anterior component separation to my retromuscular peritoneal repair or the posterior component separation to, to completely close the midline or not? I think that if you had a small bridge, it's not necessary. And also, you have to balance also regarding the comorbidities of the patient, not, as I told you, it's so difficult to compare one abdominal reconstruction with the next one. So you have to balance and indicate according to your experience and your results and your failures, your own failures.
I know we're at time, but I have a question for the audience, and then I just have a comment. How many of you guys have a SECA body scale or an in-body in your offices or have access to it? Because yeah, I do, obviously, but the SECA will give you a visceral adipose tissue volume. And if you were struggling with how much weight they lost, perhaps a way to actually measure it, maybe looking at the visceral adipose tissue reduction in terms of moving forward with surgery. I think, Dr.
Can I make one final comment? Going back to Miguel Angel, it's not easy. Sometimes these patients, a lot of these patients are not optimized. And you end up in this situation and you're trying to push things inside and everything tries to pop out because that's the reality. It's hard to do sometimes rectal dissections, etc., when patients, when everything's trying to get out of the abdomen. So the reality for me is, and it doesn't matter when I close them, they'll get an onlay mesh. And they go, even with components or without components. I think if a good onlay and very well extended, worst scenario, it gets infected, I'll put a vac on it and I'll save the mesh. Pretty much these cases are, microporous, and with antibiotics, you can do a lot of things. And if you have to come back in a later day, because these patients have a lot of recurrences, a high rate of recurrences, you go back inside and you haven't burned any bridges. So you go back to square one. At least that's what I say.
And I'll take a counter that just a bit, because if that mesh becomes infected, you try to save it. Portions are infected. Portions are got real tissue ingrowth to the anterior fascia. When you start removing it and you start damaging the anterior fascia to remove an onlay mesh that's infected, then you can really booger the whole abdominal wall. So just a point to think about.
Thank you, everyone. Thank you for the presenters. Thank you to you guys.
Pictures.